Okay guys, welcome back. I'm going to pick up where we left off with strep throat or group A strep pharyngitis. So I know I already talked about some of this, but I'm not sure how much it cut off of what I was saying. So the primary concern for pharyngitis in children caused by group A strep would be that if it's not treated properly, it could lead to rheumatic fever. So to prevent this from happening, we need antibiotics started within 9 days of the onset of the infection. So as far as the rapid strep tests go, if a child has a positive rapid strep test, that is 98 to 99% trustworthy. That is a positive case of strep throat caused by group A strep. But the sensitivity is only 70%. So that means 30% of the negative strep tests are really positive. 30% of the time it's a false negative because there's so many different serotypes, up to 80 different serotypes of group A strep. The rapid strep test can't catch them all. So the practitioner would use their best judgment based on the child's symptoms, and sometimes even with a negative test, they will still diagnose them with group A strep and treat them appropriately. So some complications that can happen with group A strep infections. You know what? I just realized my screen sharing is paused. And you guys can't see what I'm talking about. I do apologize for that. Oh my, I hope you can forgive me. That was 2 whole minutes of not being able to see. So back to where we were. With group A strep, some problems that can happen. The infection itself predisposes the child to rheumatic fever, and the main concern with rheumatic fever is the cardiac complications that can come with that. And also sometimes children can have post-streptococcal glomerulonephritis. I think we actually had a case of that this semester on the floor. Group A pharyngitis is spread via respiratory droplets. So if we have a child that tests positive for strep throat on the floor, they are actually on droplet precautions for the first 24 hours of antibiotics. And sometimes it's longer than that. It depends on the policy. It is spread via droplets through close contact. It has an incubation period of 2 to 5 days. About 10% of children seen by their provider each year have a sore throat, pharyngitis, okay? 10% of children. 25 to 50% of these children have group A strep pharyngitis. So a lot of the children that come to the doctor's office for a sore throat, 25 to 50% of them do have the bacterial pharyngitis caused by group A strep. The peak prevalence of group A strep pharyngitis is in kids 5 to 10 years of age. In kids less than 2, most of the pharyngitis that we see is viral in origin, but occasionally in rare instances, it is caused by group A strep. So you know where the tonsils and the adenoids are located, in the back of the oropharynx. They are composed of lymphoid tissue and are active in the production of immunoglobulins, B cells, and T cells. So if you did not know that, that's what the tonsils and the adenoids are supposed to do. They're composed of lymph tissue. The tonsils are more active in childhood, and so usually it's not uncommon to be able to see a child's tonsils, even if they're not enlarged, because they're just more active, being that they are lymph tissue. And as we get older, the tonsils tend to shrink in size. As far as tonsillectomy and adenoidectomy goes, we take care of a lot of children post-op after having this procedure done. Diseased tonsils are associated with decreased antigen transport, decreased antibody production above baseline levels, and chronic bacterial infection. So based on what we've just said, that tonsils and adenoids are made of lymphoid tissue, if our tonsils are diseased, it would make sense that it would have this impact on our immune system. Tonsillectomy with or without adenoidectomy is the most commonly performed pediatric surgery in the United States. More than 500,000 tonsillectomies are performed on kids in our country every year, and it's generally safe. Deaths after tonsillectomy occur very rarely, about 1 in 30,000 cases. Revisits to the hospital because of complications occur in 5 to 15% of the cases, and we say we're in clinical for 1 semester. We probably have had at least 1 patient a semester that we have seen return to the hospital due to dehydration. For example, after they've been discharged, because their throat is so sore, they just refuse to drink when they go home, and the pain is just not being managed. It's sometimes the reasons that they're readmitted would be related to bleeding, but more often what we see is vomiting or dehydration and pain. I've actually never seen one admitted for bleeding, but that doesn't mean that it's not happening. It's just not happening on the Mondays and Tuesdays when we're there. So if you look at the picture here, you can see a comparison of what infected tonsils caused by a viral infection versus a bacterial infection look like. And mainly, the main difference is with the bacterial infection, you have the pus pockets, the white spots on the back, on the tonsils that you can see, sometimes even a coating on the tongue. So post-op care. One of the big concerns is always bleeding, of course. That would be the most acute life threat would be bleeding that is not controlled post-operatively. One of the signs of bleeding would be frequent swallowing, and also vomiting, although vomiting is not uncommon because of the blood that they swallow in the OR. If they're continuing to bleed and continuing to swallow blood, the vomiting can be even more obvious, more of an issue. Assess for the swallowing, the restlessness. We're watching their vital signs, of course, and listening to breath sounds. We always set up suction if we are expecting a post-op tonsillectomy with adenoidectomy. Pain control is a big deal, whether it's IV or PO. What we're finding is that first day, they're refusing to swallow. As far as the children go, they refuse to swallow the liquid medications. And physicians and parents alike shy away from the IV narcotics, but we have a great drug called Toradol that is a strong anti-inflammatory that we can give IV that is really helping a lot. If we can get them through that first day with IV Toradol, then by the next day, hopefully the pain and inflammation has diminished to the point where now they will swallow Norco or even just Tylenol or ibuprofen. And we're seeing good results with that. Of course, we want to get them on a regular diet and keep them hydrated. If they will even swallow, popsicles, if they will live on ices, that is fine. We will let them go home. If the only thing they will drink is ices, then that's what we're going to give them for the, the first little bit to keep them hydrated. And as they heal, they will start to eat a regular diet and everything will be fine. It's the children that refuse popsicles and ices that are the problem. They refuse absolutely anything due to the pain. So our plan would be to use liquid Tylenol with or without codeine for pain control. The unwillingness of parents to give analgesics is associated with the child's refusal to eat, which results in dehydration, weight loss, and local infection. So we really need to educate the parents that without pain management, the child will end up dehydrated and right back in the hospital. They're not going to swallow unless their pain is being controlled. The patient should not be on a special diet. There's no special diet that is required. Soft foods naturally are more easily swallowed than hard foods, but there are no strict requirements as far as the diet is concerned. So individuals who should not receive tonsillectomy as outpatients are those younger than 3 years of age, those with diagnosed obstructive sleep apnea, those who live far away from the hospital or the outpatient facility, those with Down syndrome, or those who have difficulty complying with instructions. So let's look at that. Obviously, the child less than 3 years of age that undergoes an operation like this would need post-op monitoring overnight. But what about those with obstructive sleep apnea? Any patient with a history of obstructive sleep apnea is more likely to suffer from respiratory depression or respiratory arrest after anesthesia. So we definitely want to monitor those patients. Down syndrome, what comes to mind there is the large tongue that some of those patients tend to have and the risk for an obstructed airway. I can't say 100% that that's why they're on the list, but I think that that would be one of the reasons. In those who have difficulty in complying with instructions or those who live far away, that's at the physician's discretion. If they're worried that this kid's going to get out there in Timbuktu and not be well monitored or taken care of appropriately, then they can make that call that this kid's going to stay overnight. And that happens. Okay, now moving on. Sorry, I had to pause there to talk to my daughter, and it seems like it's recording my words even when I mute myself. Okay, apnea. Let me make sure. Yes, we're recording, we're sharing, and I'm not muted. Okay. On page 1054, I want you to compare apnea of prematurity with infant apnea. They are two different beasts. And I want you to review the nursing care of the infant with apnea. We are not talking about apnea of prematurity for the most part here. Apnea, what is it? Apnea is a pause in breathing greater than 20 seconds. So on the monitor, there is an option when you set your alarms for respirations to set it for apnea greater than 20 seconds. So that is the definition of apnea. Usually it does not happen alone. If an infant is on the path to having an apneic episode, by the time they reach 20 seconds, and oftentimes sooner, you will start to see a color change. You will start to see bradycardia and a tonic change, a change in their tone. If they truly have an apneic spell, it is accompanied by bradycardia and that color change, be it cyanosis or pallor. and frequently they become floppy. Um, it is very terrifying for the family, and this is not the same as apnea of prematurity. This is in an infant that is term. An apneic episode can be the first sign of illness, particularly respiratory illness in a newborn. That's also the case with premature infants, but that's just not what we're talking about in a bubble here. We're talking about apnea in an infant. So on that note, I want to talk to you now about something called a BRUI. It was called an ALTE, acute life-threatening event. It has been changed to BRUI, which is a brief, resolved, unexplained event. The term BRUI is deemed less frightening of a term to parents. Acute life-threatening event, having that on the child's medical record, just truly, I mean, when the kid's 20 years old, the parents will still be talking about the acute life-threatening event the child had. It just, the term in itself is traumatic. So we've changed that to brief, resolved, unexplained event, and that's a little less scary. This usually occurs in an infant less than 6 months old. It is witnessed by a caregiver. It may require stimulation to resume responsiveness, and typically by the time the ambulance arrives, the infant seems fine. They appear normal. They are usually admitted to the hospital for monitoring and a workup. What kinds of things do we need to work up? Well, we've got to figure out why the kid had this apneic episode, this brief, resolved, unexplained event. This event could be described by the caregivers as, I don't know what happened. All of a sudden, he started, I looked in the crib and he was blue, and he was foaming at the mouth, and his eyes were wide open, and then he just went limp, and I had to shake him, and I had to give rescue breaths, or I had to start CPR, and then all of a sudden he just came out of it and started screaming, and it scared me to death, and I called 911. Sometimes it seems like the child choked. They just can't figure out exactly what it is that happened, but whatever they saw, whatever the parent witnessed, it terrified them, and they called 911 thinking this was it. But then by the time EMS arrived, the child was recovered. So we've got to figure out what happened and how likely is it to happen again, how life-threatening, is the root cause of what happened. So we've got to rule out things. For example, abuse. Could the child have suffered a head injury? Could the child have been shaken earlier in the day and, maybe at the babysitter's, and the parent picks them up, and this happens as soon as they get home? Maybe it's sequela of what happened to the babysitters. Maybe the parent did it themselves, and an hour later, they witness this episode, and you just never know. Sometimes parents don't realize their own strength, or caregivers. So we've got to rule out abuse as the cause of this spell. Infection, like we said a while ago. Sometimes apnea is the first sign of respiratory illness. So in ruling out abuse, we might be getting things like CT scans of the head, x-rays. To rule out infection, one of the first things that we do is a viral respiratory panel, that Q-tip in the nose, to check for viral illness. Another common cause of BRUIs are reflux spells. The acid reflux comes up because the lower esophagus is very immature in the newborn, and that sphincter is weak, and because of its immaturity, the baby refluxes, and that acid startles them in the back of their throat, and they hold their breath because they are startled. And if they don't resume breathing in a timely fashion, it's hard for them to recover. And in a lot of cases, it does end up being reflux. What if it was seizure activity? We have to rule out seizures. Another thing is cardiac anomalies. This is in a newborn or an infant, so it's possible that they could have an undiagnosed congenital anomaly related to their heart. And there are other metabolic anomalies that we are continually discovering that we may need to rule out. As far as the nursing care for this child goes, it is usually just educating and supporting, emotionally supporting the families. The baby's fine almost every time. The baby is does not have a repeat episode while they're in the hospital and being monitored closely. We usually don't witness anything. We only find a cause in about 50% of the cases. So that's upsetting to the families. They want to know what happened, and they want to know why. They want to know how to prevent it. And when you tell them there's a 50-50 chance that we figure out what caused this, that can be very upsetting. And just the fact that they witnessed what they did in itself is traumatic. So it's mostly giving support to the families while we're doing the different tests. So here we have a snapshot of the practice guideline according to the American Academy of Pediatrics. And you can read this, but basically a bruit occurring in an infant less than 1 with a brief now resolved episode of greater than or equal to one of the following. So to be labeled as having had a brief resolved unexplained event, the infant is less than 1 and they had a brief now resolved episode of at least one of the following things. A color change, whether that is cyanosis or pallor. Absent, decreased, or irregular breathing. A marked change in tone. They got floppy or stiff, whatever it is. An altered LOC, an altered level of consciousness. So they're less than 1 and they have a color change, some type of abnormal breathing, a tone change, or an altered LOC, at least one of those things. We diagnose a patient with a brief resolved unexplained event only after no explanation is found after a thorough H&P is performed by the provider. And then the article goes on to discuss low risk versus high risk infants following an event, because we have to figure out, well, what do we do now that this has happened? Which kids are at risk of this happening again compared to the ones that we feel pretty comfortable we could send home without further testing or a home monitor. And as you can imagine, if they were a preemie, if this has only happened one time, if it happened for a very short period of time, if it did not require CPR, those kinds of things would be less concerning than if it had occurred in a preemie that was sent home, a baby that only weighed 4 pounds and they really aren't even at full term age yet. And the parent did have to perform CPR, those kind of kids would be considered high risk. Okay, so the next thing we're going to talk about is Croup. The big word for croup is laryngotracheobronchitis, or LTB. Laryngotracheobronchitis, LTB, croup. They're all the same thing. Croup is the most common cause of hoarseness, coughness, is that a thing? Hoarseness, coughing, and acute onset of stridor in febrile children. So you have a kid with fever, they're coughing, they're hoarse, and all of a sudden they're making a stridorous noise. Croup is the most common cause. They may or may not have coryza, C-O-R-Y-Z-A. That is a runny nose. They may have it bad, they may just have it a little, or it may not at all. So what is stridor? Stridor is an audible, harsh, high-pitched sound on inspiration, not expiration. Wheezes are typically the high-pitched sound heard on expiration, but stridor is on inspiration, trying to get air in. It's produced by turbulent airflow through a partially obstructed upper airway. So it's very different from wheezing. Wheezing is trying to get air out of the lower airway that is partially obstructed from swelling or mucus. Stridor is trying to get air in the upper airway that is swollen. It's edematous, and they're trying to get air in. And the noise, this can be a noise that is so loud that you can hear it from the door, or it could be so mild that you can only hear it with a stethoscope when you place the stethoscope over their throat, over their upper airway. The vast majority of children with croup recover just fine without sequelae or consequences, but it can be life-threatening in very young infants. So it looks scary when you have a baby that is running a fever and has stridor, but what the previous statement is saying is, although it looks scary and it makes the children feel bad, it's a virus, and usually they get through it and they do just fine. But of course, the younger, smaller the body and all of that, it can be life-threatening. So young infants who present with stridor, we've got to look at them very closely to determine, is this a viral croup, or is this something more life-threatening, like a bacterial infection? Croup is a virus. Croup is a symptom of a virus. It is typically caused by a virus, and we will talk about some of the viruses that can cause croup. Usually croup is a mild, self-limited disease. Upper airway obstruction, though, can cause respiratory distress and possibly a risk of death. Look at page 1043, table 45-2, and it will talk some more about this. This respiratory illness FYI is recognized and has been recognized by physicians for centuries, and we know that because croup derives its name from an Anglo-Saxon word, cropan. It's spelled K-R-O-P-A-N, cropan. Some think that the word croup comes from an old Scottish word, roup, R-O-U-P, meaning to cry out in a hoarse voice. So if croup, the word croup, comes from an old Anglo-Saxon word or an old Scottish word, croup must have been around for a long time, right? So here I've given you a link. Let's just see if this will work for us. Depending on my internet. Let's see if we can hear anything. Waiting, waiting, waiting. Okay. So let's see. Not sure which one to click on, but let's try this one. Strider audio. I'm not hearing anything. Okay, let's go back up here. I know you could play with this on your own time, but I'd like for us to hear it. Let's try it.
Please register to listen to these long sounds.
I have registered. Okay, well, you guys can do it on your own then. I'm sorry about that, but anyway, I tried to give you something where you could hear Strider, and I can probably, well, I don't want to take up any more of your time. You can do that on your own, but there's all kinds of great websites that you can go to hear the different breath sounds, and I encourage you to do that. Now, let's get back to where we were. Okay, so you just click on that link when you can, and I'm pretty sure it's free to register for this, and try to listen to those. So here's my little joke of the day. Why do I have this little guy in the window? Here we have a kid coughing, and what is this? This is a seal. And I have this here because they say that the cough that goes along with laryngotracheobronchitis sounds like a barking seal. Croup manifests as hoarseness, a seal-like barking cough, inspiratory stridor, and a variable degree of respiratory distress. The anatomical airway that is impacted is the narrowest part of the pediatric airway. If you will recall, when we looked at the very first slides about the differences in the pediatric airway and the adult airway, how narrow the pediatric airway is, that's why croup makes kids, look so terrible, because it is impacting that narrow airway. That being said, the swelling can significantly reduce the diameter of the airway, limiting airflow. That narrowing results in the seal-like barky cough, turbulent airflow, stridor, and chest wall retractions. So, what do we know about croup? To review, well, some of it's review. Number one, croup is a virus. I don't care how they word it in your book. I think I forgot to tell you this at the beginning. Some books like to talk about croup as a group of illnesses, and they include any kind of illness that causes stridor. One of those illnesses is a bacterial illness that we're going to talk about next. And I think that confuses, if you call that illness a croup syndrome, I think it confuses the picture. When I think about croup, I equilibrate. Croup equals laryngotracheobronchitis and that equals a virus, a viral illness. And I don't like to mix anything else with that. Now, what virus causes croup? We know that 80% of the time, croup is caused by parainfluenza. That's the name of the virus. There are a couple different strains, parainfluenza 1, 2, and 3. Don't worry about that. We're just saying parainfluenza is the cause of croup 80% of the time. Mycoplasma has even been indicated in some cases. The flu has been indicated. But let's just try to remember that croup is viral. Croup is the same as laryngotracheobronchitis, and 80% of the time, the virus to blame is parainfluenza. We know that croup causes an acute upper airway obstruction. We know that croup causes a seal-like bark with inspiratory stridor and hoarseness. And we know, which we haven't talked about this yet, but those of you with children know that croup tends to be worse at night. At night, you think, oh my goodness, I'm 1 minute away from taking them to the hospital. And then the next morning, you're so glad you didn't because they're running around playing, acting like they're fine, maybe just with a little runny nose. You don't even go to the doctor because they seem fine. Then the nighttime comes again, and here we go all over again, and you're kicking yourself because you did not take them to the doctor earlier. That's typical of croup. It's worse at night. In North America, the incidence of croup peaks in the 2nd year of life. So on the slide here, it says it tends to happen between 6 months of age to 3 years, with a peak of 2 years of age. We have an incidence of about 5 to 6 cases per 100 toddlers. So when you think about croup, when you're studying it, think about toddlers. That would fit for your 2-year-olds. Toddlers, and it's uncommon after age 6, but it can still happen. We've even diagnosed croup in the preteen and adolescent years, very rarely in adults. Typically, this is a toddler, and it's worse at night. Some evidence suggests that hospitalization for croup may be associated with future development of asthma. So what that means is, if the kid's croup symptoms are so bad that they require hospitalization, they may be prone to developing asthma later in life. Remember, this is a toddler that we're talking about, so most likely, if they're going to develop asthma, that has not happened yet. So with croup, we also have a mild fever and mild upper respiratory symptoms like runny nose and sore throat. Something I want to mention briefly is called spasmodic croup. It is similar to that of the croup that we just talked about, but spasmodic croup is not accompanied by the symptoms of illness like fever and runny nose. Spasmodic croup always occurs at night, and it has the hallmark of reoccurrence. It just keeps happening, and the kid's not sick. There's no illness that we can put our finger on, but at night they just tend to develop these croup symptoms. Maybe there could be a certain viral illness that triggers this to recur in children. Maybe it's some type of allergy. We really don't know. But kids basically have the symptoms of croup at night, but no fever and no runny nose. And it only happens at night. And that's termed spasmodic croup. Okay, let's look at this. We have a healthy trachea and we have a croup trachea, a croupified trachea. You can see, get my highlighter here. Or let's see what I want. I want my little laser pointer. Here we have the pink areas. That is the mucosa that is swollen. And the lighter pink area is the airflow. So you can see how the airflow becomes narrow when the patient has a swollen airway due to croup. Whenever you look at that on an x-ray, it can give us something called a steeple sign. And also, look here, it's showing you that in this narrow part of the airway where the swelling tends to occur, that's where your voice box or your larynx sits. And that's why the children also sound hoarse. So back to the steeple sign. So most children with croup just have a croupy cough and a hoarse cry. Some of them have stridor. Some have stridor only when they get upset and start crying, or they're playing too hard, or they're agitated. Whereas other children have stridor so bad that you can hear it even when they're laying still and resting. And they are accompanied by signs of respiratory distress along with the stridor. So the variation of severity is wide. Children with more severe cases have inspiratory and expiratory stridor at rest with visible suprasternal, intercostal, and subcostal retractions. And they can even have, poor air entry when you're listening to them. So the ones that we're worried about are the ones that really are showing us signs of stridor at rest, along with respiratory distress signs. So what I'm showing you on this picture here is something called the steeple sign in cartoon form. And now I'm going to show you in real life how we can have a steeple sign appear on an x-ray. Now, 50% of the time, we will not see a steeple sign, even though the child has clinical symptoms of croup. But it is something that is a useful tool to help confirm the diagnosis being croup. It's not required to get this x-ray and have this confirmation, but it's just helpful. And it, like I said, it may or may not even be present on the x-ray. So you can see where on our cartoon drawing where the steeple sign would be, and sure enough, we have, let me make that bigger. Here you have that. This is called an air bronchogram, when you can, well, I guess when the air is down in the bronchi like that, you can see it. It's called a bronchogram, but you get what I'm trying to say. Where you can see the dark area, that is air. And you can obviously see how it narrows here because of the mucosal swelling here on either side. Air should be black, always. Air is black and solid tissue is white. Dense tissue is white, air is black. So that's the steeple sign. There is something called a Wesley score. You do not have to know this or memorize the scoring system, but I just want you to know there is a scoring system that helps determine how bad the croup is. The Wesley score evaluates the severity of the croup, and it assesses these 5 things: LOC, cyanosis, stridor, air entry, and retractions. So if they have a score less than 2, they're considered to have mild croup. And the good news is 85% of children that present to the emergency department are considered to have mild croup. They just have occasional barking coughs. They do not have stridor at rest. And they usually, don't have retractions. If they score a 3 to 5, then they're considered to have moderate disease. They do have audible stridor, They do have retractions at rest, but they're really not showing signs of distress or agitation. And then if they score 6 to 11, they're considered to have severe disease, and that is rare to have a score of 6 to 11 with laryngotracheobronchitis. You know, if they were greater than or equal to 12, they're about to quit breathing. That's impending respiratory failure. So, point to remember, the Wesley score is a scoring system to help practitioners objectively identify the severity of the croup. Most, 85% of the children, most of them have a score of less than 2, giving them a label as having mild croup. But then the rest of them tend to have moderate disease, and they may have audible stridor with retractions at rest. As far as the labs go, we may check a CBC, and that could tell us if they have a normal white count with lymphocytes that are rising and may even be dominant at this point. That would support a viral diagnosis. And we will most likely do a viral respiratory swab if we're in an emergency room or hospital setting. And that swab can identify parainfluenza. And if we have a CBC that supports a viral illness, and we have a viral respiratory swab that comes back with a detection of parainfluenza, then croup just, you know, that's it. It all makes sense. We've got an obvious croupy kid, we've got a viral CBC, and now 24 hours later, sure enough, we come back with a positive parainfluenza. FYI, parainfluenza requires contact precautions, whereas if it was caused by mycoplasma or the flu, we would be wearing our mask. Treatment. What are you going to do about it? Well, the number one thing to do is to keep the child calm, because no matter if they are mild or moderate in severity, agitation will make it worse. If they're not having stridor at rest, but you agitate the child and have them crying, whether it's by trying to start an IV or taking them away from their parents, you're about to hear what stridor sounds like, because it just causes it. Allow the child to maintain the position of comfort. So we're going to avoid unnecessary painful interventions with these kids. Anything that's going to cause agitation is potentially going to worsen respiratory distress and lead to increased O2 requirements. Persistent crying increases oxygen demands, and respiratory muscle fatigue will worsen the airway obstruction. So we're going to have medications that we're going to need to give, but we're going to try to do that in the least traumatic way possible. We're going to have emergency equipment at the bedside just in case, and no matter what, in any child with stridor, we do not attempt to examine the throat. That means don't have them open and say, ah. We don't look in the throat. We don't swab the throat. We don't do anything but keep them calm and let them stay in the parent's lap. While that's happening, we are carefully monitoring their heart rate for tachycardia. We're monitoring respiratory rate for tachypnea. We're watching their work of breathing to assess for retractions. We're monitoring the pulse ox for hypoxia. All of those things are very important factors that will help determine whether or not they need to be admitted. Given the risk of increased insensible water losses from fever, tachypnea, a history of decreased oral intake, we also need to assess their hydration status. So what kind of medications do you think we would give for croup? A viral illness causing fever, runny nose, and a swollen airway. So obviously we're going to treat the fever, but let's focus on the airway. What are we going to do? What can we give IV or IM or even orally that would help with the inflammation within the airway? Decadron. Decadron is a steroid that has proven beneficial in severe, moderate, and even mild croup. So we get our steroids on board. The other thing that will have a localized action on that swollen airway would be racemic epinephrine, otherwise known as VAPO. So here we go. I'm going to try to write on the screen. And you know how that went last time. But I'm going to do it. V-A-P-O. VAPO. That stands for vaponephrine, like epinephrine. So you could say nebulized epinephrine, or you could say vaponephrine. Vapo is in the air, aerosolized, and we just say vapo as short for vaponephrine. So they get a breathing treatment of epinephrine, basically. And that epi, what does epi do? Think about epi. What do you know about epinephrine? Anything? When we use epi IV for someone in cardiac arrest, we are wanting, one of the things that it does is it vasoconstricts. It tightens up our vasculature. It vasoconstricts. When we give lidocaine with epi as an injection before a doctor sutures a head wound, a head laceration, why does the lidocaine have epi in it? Because the epi causes incredible vasoconstriction, because head wounds bleed a lot. We never give lidocaine with epi for a finger laceration before a doctor sutures a finger, because the vasoconstriction caused by that lidocaine with epi could cause loss of blood flow to the digit. So when we give aerosolized epinephrine in the form of vaponephrine to a child with croup, it will have an immediate action on the swollen tissue in the airway. The other word for vaponephrine, can think of vaponephrine as a trade name. The other word is, I really can't spell this out, I don't think, but the other word for it is racemic. Racemic epinephrine. Racemic. Look at me. Getting better at this. It still looks terrible though. Vaponephrine or racemic epinephrine. And I don't have a trick to remembering racemic, except that epi makes your heart race. If the doctor says, go get, let's get some racemic on board, or let's get some vapo on board, they mean the same thing, and different people tend to use these words interchangeably. They're the exact same thing. Racemic epinephrine or vaponephrine, same thing. So steroids and vapo or racemic epi, oxygen if needed. Those are our three medications. The parent can hold the breathing treatment of vapo in front of their face. You do not have to strap a mask onto the child. That's only going to make them more stressed out. Just in the least invasive way, get that treatment on board. If the child is at home, we recommend a cool mist from a humidifier and or sitting with the child in a bathroom that is filled with steam generated by a running hot water shower. That you are not supposed to be literally in the shower with the child. We just encourage the parent to go in the bathroom, shut the door, turn on the shower full blast hot, and steam up the bathroom and sit in there with the child. Or you will hear parents say that they take the child outside in the cool night air, and that seems to help. So whatever works for them, but those are the two suggestions for at home. So that's the end of part 1 for respiratory. This will be the end of what you will be tested on exam 2. And we will start respiratory part 2 after exam 2. Respiratory part 2 will start, I believe, with epiglottitis. I think that's where we pick up. So let's look back. We have croup that we talk about, and we have bruits, or brief resolved unexplained events. Hang on, I lost my mouse. Okay, we have apnea, tonsillectomy and adenoidectomy. Group A, strep pharyngitis, and viral pharyngitis. Those are our disease processes that will be covered on this test. Before that, in respiratory, we just had some basic review of the types of retractions and the types of distress, and just talk about how to assess work of breathing and anatomical differences in children versus adults. So I hope that was a decent introduction to respiratory, and that you are ready for exam 2. And I think you have what you need. See you later.